Good afternoon. Thank you for joining me for this presentation. A couple of caveats before I get going. A number of the presentations you have heard were very oriented towards potential candidates, those persons with epilepsy or caregivers regarding the opportunities for participating in trials. My talk is a little bit different. If you are scientifically inclined, come forward because you would want to see the slides in greater detail. I realize the monitor is a little small for the size of the room. My talk is oriented a little bit differently. My talk is kind of technical because what you heard until all morning, all afternoon, was about existing trials about new products. Mine is a little bit oriented towards actually eliciting investigators to appreciate what is going on in the design of new drugs at a more technical level. Secondly, we heard some very exciting things about gene therapies, antisense oligonucleotides, but one of the things you notice is kind of like after epilepsy surgery or neurostimulation, just about everybody is on small molecule therapy. So my cultural origins are, before I went to medical school, I was a medicinal chemist, so I obsess over refining, improving small molecules. So that's kind of my baseline orientation. Secondly, I think many of the gene therapies are not going to be accessible to vast majority of patients worldwide. So again, small molecules are really important. My goal is to point out that we have all been sort of lectured on Quan and Brody and what defines refractory epilepsy. Mine is kind of the anti-Quan and Brody talk to tell you that synthesis of new medications is also benefiting from our new DNA genetic knowledge. And that's sort of the big picture of my talk. So pardon me if it is too technical, because it was designed to be, okay? But if you are not a technical person, you will still get the message. You just may not understand all the nitty-gritty, but that's okay. My point is, a lot of my own colleagues don't always get into the nitty-gritty, and I'm kind of inviting them to do so they can wisely understand what's going on with medications. So with that, let me quickly scan my disclosures and move on to some very basic concepts. Everybody is taught that there is an imbalance between excitation and inhibition. You just moments ago heard about gene therapies to increase inhibition. You just heard about, instilling inhibitory cells. Earlier you heard about blocking, excitatory cell glutamate expression. You also heard about the small molecule therapy from Grin Therapeutics, about blocking glutamate on the NMDA receptors. So we always come down to this. Historically, we thought when excitation was heavier than inhibition, we got seizures. And that was said to be either too much sodium channel activity or too much glutamatergic activity. On the inhibition side, we have potassium channels that you heard a little bit about, and you're going to hear more about from me, or decreased GABA activity, the universal inhibitory neurotransmitter. But in the new genetics era, we have learned that things are a little bit more complicated. That is, we said increased sodium channel function gives rise to epilepsy, but we know in one case at least, very clearly, loss of function in the sodium channel gene, SCN1A, it basically stands for SCN is sodium channel, 1A is the alpha-1 subunit, right? Where we got Dravet syndrome and GEFS plus that you just heard about. So we need to understand this a little bit more. So I'm going to use this illustration of the action potential. I just borrowed this from the web, but I'm going to impose on it what a lot of neurologists are learning from gene testing and the genes involved. So here's that action potential, and I want to draw your attention to the resting potential that is labeled and the voltage threshold beyond which sodium channels are wide open. And now we know that the genes that regulate this are SCN1A, 2A, and 8A, referring to specifically currents that NA sub V 1.1, etc. The sub V means voltage gated, right? Now, after these channels open and the sodium rushes in and the membrane potential rises, what happens next is there is going to be a rapid closure of the sodium channels, with one exception, that is the NAV 1.1, the gene product of SCN1A, invariably closes very rapidly. It gives rise to a sharp spike. However, with 1.6 and 1.2, under normal circumstances, they are supposed to, but with mutations, they may not close completely, leaving a residual current that we are going to call persistent sodium current, or INAP. And of course, after that high voltage is achieved, next thing, potassium channels open. Those are the KV 1.1 and 1.2 channels that give rise to repolarization. And then there are other genes involved in the hyperpolarization zone. There are the KCNT1 or KCNQ2/3. We're going to hear more about it in my talk. Okay? The other thing is SCN1A subunits, the ones that mediate the NAV 1.1, are restricted to a subtype of GABAergic interneurons. These are in fact the interneurons you just heard about being instilled in the Neurona trial, right? These are the parvalbumin co-localizers, and they give rise to a very sharp release of burst of GABA, and they are involved in axosomatic inhibition, right? Those are the only ones that have NAV 1.1, whereas 1.2 and 1.6 are seen in principal cells. So this is going back to the classic times. I wanted to show you this paper. This goes way back to 1964, long before I had thought of medical school. And this was a paper led by Cosimo Ajmoni Marsan when he was at the NINDS. You'll notice in those days it was the NINDB for blindness rather than stroke. And this is a very, very key paper. They tried to understand what is actually going on in the epileptic focus, right? And what they did was these old-fashioned recordings. You can see oscilloscope recordings where you see spikes living on a bump, okay? So I'm going to show you, this is for historic reasons. It was published in Science, a very high-impact journal. And in the next slide, you can see it a little clearly. Again, another legendary neuroscientist, David Prince at Stanford. He shows you a number of these bumps with a number of spiky things on it. So what it is the baseline on these drawings is your resting membrane potential. What causes the spikes to appear is that bump. That bump is what takes the membrane potential towards the threshold for firing, a chain of action potentials. So the key thing in the epileptic neuron appears to be the ability of them to get partially depolarized and go closer to the threshold so they start firing. Okay? So here is another one. Again, to show you this concept is new. This is a paper from 2025. I simply wanted to show this to you to emphasize that Kosi Ajmoni Marsan's findings are still true. We still believe that the paroxysmal depolarization shift, which is what we call that bump, is very, very important. Okay? And it can be triggered by a number of means, like GABA receptor antagonists, potassium channel blockers, high potassium in the extracellular space, and so on. These are all number of ways by which people in the laboratory can make these cells develop that bump, which makes it possible for repetitive neuronal discharges. Okay? So this is a classic paper by Bob McDonald when he was in Michigan that showed that a number of medications like sodium valproate, phenytoin, carbamazepine, all of them had the ability to block this repetitive neuronal firing. So what you see here is current is injected, whether at 0.8 picoamps or 0.5, it doesn't matter, beyond a certain threshold, particularly when you hit 0.8 or even 0.5, you see very robust firing, and then it is blocked by these medications. These are sodium channel blockers. Okay? Now, here I want to show you the two types of sodium current I mentioned. The one that is particularly important and exclusively in NAV 1.1 is the transient sodium current. That's that spiky thing in the orange oval. And then in the blue, you can see that the current has not returned to the baseline. That's the persistent current, right? And it turns out when you have mutations in some of the sodium channels, particularly SCN2A or SCN8A, you end up with a residual current. But it has also been shown if you take laboratory rats, give them status epilepticus, and then let them develop temporal lobe epilepsy, mesial temporal epilepsy, during that period they develop bursting neurons that show increase in persistent current. So the persistent current, we went too fast. Yeah, no, here we go. So this is just showing you that when you have a gain of function mutation in sodium channel NAV 1.6, there is more residual. You can see persistent current in the figure, wild type versus mutant. So it's definitely there in human epilepsy with inherited conditions. This could easily be 2A. Here is another one showing you cellular recordings, and you can see in black in the green box the normal function. That's the wild type for WT. And here you see a mutation where the magenta recording doesn't come all the way to the baseline. So just to show you that these are genes in which persons have mutations. Okay? Then this is the study I mentioned to you about giving rat status epilepticus and letting them develop this kind of temporal lobe epilepsy, whereby again there's an increase in persistent current. And then finally we have human resected tissue. These are surgical specimens where again there is increase in persistent current. So whether it's in the laboratory rat or in human acquired epilepsy or in human genetic epilepsy, wherever you see, the bottom line is a persistent sodium current. Okay? Now, one of the very recent studies, very exciting concept. This is a paper from, as you can see, this year from Brain, from a very famous laboratory of Jeffrey Nobles. And what this particular one shows is that when there is persistent sodium current, right, in the SCN8A mutation mice, what he found was they can readily develop, along with their seizures, spreading depolarization, or SD. The so-called spreading depolarization is what people in the past used to refer to as the spreading depression of Liao. It's very well known into the people who treat migraine. What they are showing is in both potassium channel mutants, the M-type potassium, that is the KV7 channel, those that have loss of function mutation in that, or in the persistent current with SCN8A, in all these conditions, after the seizure, they facilitated the spreading depolarization. And what they found was if it really spread all the way to the brain stem, it can shut off the cardiorespiratory center. So this is really a mechanism for SUDEP. And they're showing again there is a relevance to increased INAP, persistent current, and SUDEP. Okay, so now we come back to this drawing that is kind of in EEG 101 for neurologists. I'm going to put a box to focus on. Again, they showed that paroxysmal depolarization shift. So even in that literature, you see that bump is necessary to make the spikes happen. Now, this one says, in that bump, it says non-NMDA or NMDA, because they used to think this was a calcium current, but I have already shown you ample evidence that actually this can be a persistent sodium current. Okay? So that is a very, very important idea, the paroxysmal depolarization shift. This is from a recent book, article by Prince and Evoli, again in May 24, emphasizing my obsession with the paroxysmal depolarization shift and how to modify it. And here again you see how you can generate it with penicillin, etc. Okay? So coming back to this, I enlarged that point to show you that that bump, or the paroxysmal depolarization shift, is INAP, or a sodium current. The action potentials, the train of them you see, are the transient current. And I want you to know that the persistent current is contributing to PDS in both acquired and genetic, as I told you. And then I want to talk about inhibition a little bit. Inhibition is very, very important. And in this two diagrams, I show feedback versus feed-forward inhibition. In feedback, the output from the gray pyramidal-looking cells drives the turquoise cell that looks kind of bipolar, and that's the GABAergic interneuron. In the feed-forward, the incoming volley and directly activating both the inhibitory cell, which in turn connects to the excitatory cells. So in the complex architecture of the cerebral cortex or the hippocampus, the inhibitory interneurons play a significant role in modifying the output. Okay? And what I also want to know is those turquoise cells, in order to activate them to squirt GABA, you need a sodium current. That's the NAV 1.1. Whereas the principal neurons mainly have NAV 1.6 or 1.2. Okay? And you don't have to read all this. I'll highlight what you need to know. NAV 1.1 is only there in the GABAergic interneuron. That's the one encoded by SCN1A gene. These are illustrations emphasizing the same thing. NAV 1.1 is specifically in the GABAergic interneurons. And here is a schematic where you can see the NAV 1.2 and 1.6 along the length of the axon. NAV 1.2 is very dense, very close to the body. And then as you go further out, there is more NAV 1.6. And the impulse moves along because NAV 1.2 has a higher threshold. So you don't get retrograde. NAV 1.6 fires easier. So impulse moves down the axon. An important thing is this is also the same location for the Kv7 channels. So these channels that you earlier heard from Dr. Nair as the brake, right? The accelerator is the 1.2 and 1.6. The Kv7, the KCNQ2 gene coded products are the brake. They also exist in that same location. So it's that balance that's going to be critical. So you have a couple of options here. To block this progression, you can actually block NAV 1.2 and 1.6, or you can goose Kv7, right? And that's the approach you heard from Biohaven, And that's also the approach you heard from other companies like Xenon, okay? And as you will hear shortly, Jazz is kind of jumping into that, okay? All right, so this is a schematic I made to put this all together to show you that there is that GABAergic interneuron that needs to be activated with NAV 1.1. In the axon initial segment of the principal cell, we have 1.2, 1.6 sodium channels and the Kv7, right? So we can block sodium channels there or promote Kv7. If you do any of them, you leave the GABAergic cell alone because that GABAergic cell is your friend. There is no profit in blocking them. What the classic medications did was they blocked all the sodium channels. So the great improvement in emerging drugs is we do not block what's actually beneficial to us, okay? So moving along that, the first available drug that accomplishes that is cenobamate. And what you see here on the left panel is the transient current. You can see that control and cenobamate look about the same, meaning it's not blocking NAV 1.1. This means your inhibition is intact. There is no kneecapping of inhibition as a sideshow, right? On the persistent current, you can see in the middle panel, is decreased with cenobamate. And on the right extreme, you have a dose-response curve that shows that, So on the right extreme, you see in the dose-response curve that the impact on the persistent current, that blockade, occurs at at least tenfold or maybe more lower concentration than any effect on the persistent current. You can block up to 80% of the persistent current and there is very little impact on the transient current, meaning intact inhibition. Okay? So consistent with that, this paper showed from Berlin that a number of adult patients, their seizure frequency is on the y-axis, the zero time on the x-axis is when they went on cenobamate, and you see a dramatic reduction in seizures. This is contrary to expectation because people used to teach that you should not use sodium channel blockers on these patients because they already have an impaired SCN1A mutation that's hurting their interneurons. So this is a good demonstration that selective sodium channel blockade affords this kind of efficacy. So this idea is not lost. So the folks at Xenon, even though they are talking mainly about their Kv7 drugs here, you can see that they have a busy group of medicinal chemists and pharmacologists who are making compounds that are very exciting to me. This one talks about selective NAV 1.6 inhibitors. And I'm going to show you a very interesting data here. So if you look at the right bottom left, there are dose-response curves. The inverted blue triangles are the effect of this medication on NAV 1.6. The orange boxes are NAV 1.2. The red circles are NAV 1.1. So here you see almost 1,000-fold difference in effect. So on the top right panel, you can see here pyramidal neurons versus fast-spiking interneurons and the effect of carbamazepine. What you see there is carbamazepine is inhibiting the current with both pyramidal neurons, the principal cells, and the inhibitory interneurons very, very similarly. Whereas the test compound, you can see, has a very similar effect to carbamazepine on the pyramidal cells, however, not on the cortical interneurons. So this is exactly what I've been talking about. So further emphasizing, here you have a compound on top left, XPC 7224 made by Xenon, that's mainly NAV 1.6. On the top right, You see the orange box is the most sensitive one. That's the NaV 1.2. So the message to neurologists is specific compounds are emerging for all these gene mutations you see, like gain of function in NaV 1.6, 1.2, and compare that to the traditional sodium channel blockers below, phenytoin and carbamazepine. You see there's no selectivity at all. They block everything very, very similarly. So other advantages are NaV 1.5 is the cardiac channel. You remember the potential for cardiac toxicity with phenytoin, right? So there's much advantage in selectively, isoform selectively blocking sodium channels. So this is again a graphic illustration of the same thing, showing phenytoin and carbamazepine inhibiting both GABAergic inhibitory neuron and glutamatergic excitatory neuron, whereas the preferential compounds made by xenon. And that is kind of what we have right now on hand with cenobamate on the sodium channel side. And interestingly, there are also maybe of relevance to like a Dravet mutation is this compound. Here you see it activates 1.1. So we don't have any clinical trials on this kind of compound at this point, but this is also a potential way to accomplish roughly what some companies such as Stoke are trying to do, which is enhance 1.1 action, right? But without gene therapy. So this is to show you three kinds of sodium current. The black one is the eye transient, right? Then I showed you the blue, the persistent current. What I have not talked about is what's in green. That's another whole new animal. That's called the resurgent current. Turns out mutations in SCN2A and SCN8A can also give rise to resurgent current. What happens is, you see the channel is supposed to close promptly. Then you got a sharp one. When the channel is unstable, when it closes incompletely, you get a persistent current. Or if it kind of closes but doesn't stay shut, it's kind of like your latch didn't click and the door opens again due to a breeze, that's your resurgent current. Okay? So what we show here is something that was seen with cannabidiol. So usually when you go to promotional lectures, we always get that disclaimer, we don't know how anything works, which is kind of the dumbest thing companies want speakers to say because they think that's what FDA wants us to say. But we are spending as a government a lot of money on research. It's time to stop being dumb and being smart, okay? So this is one of the mechanisms. Here you see a very strong, robust resurgent current that is truncated substantially by cannabidiol. That's all I wanted to show you here. And here is another paper on cannabidiol where you can see the impact on both not only resurgent current, but also on the persistent current. And no wonder that the first indication cannabidiol had was from Dravet syndrome. That totally kind of makes sense, okay? And this is just a magnified view showing both resurgent and persistent current are blocked by cannabidiol. It's not the only thing cannabidiol does. It's got a very complex pharmacology, including G protein coupled effects on neurotransmitter release. But I think it's very relevant to what we're talking about, okay? So at the moment, Praxis is developing new compound. I want to focus a little bit on the one on the left, which seems to be somewhat selective to persistent currents, that is relutrigine. And here you can see a very nice demonstration of the difference. You see with carbamazepine, look at panel below, that's marked D. That's very much like what I showed you from Bob McDonald's lab with valproate, phenytoin, all those. You add carbamazepine and the repetitive firing stops. That's because here you see the persistent current is being artificially forced. the important thing is this tells you that carbamazepine blocks the transient current. And that's exactly what you would rather not have, because that's the type of current the GABAergic interneurons have. If you look on the top under panel A, you notice with the current injection, you can see from black versus blue, there's no difference. Meaning it can block the persistent current at that concentration, but if you force the persistent current artificially, it cannot block the transient current. So that's exactly the point I'm trying to make about the new compounds, right? But you can see on panel C the reduction in persistent current. Got strong CNS distribution. And here again, I compare that to you. You can see the old Bob McDonald drawing. All those classic drugs block transient currents. The main thing you see with Prax 562 with this, which is relutrigine, is those repetitive spikes are there. Meaning it cannot block those, but it will block the persistent current, so it's actually a very potent anticonvulsant that's not going to mess as much with GABAergic interneuron, the recurrent message. Okay? So if you want to read more about this in a user-friendly fashion, at least for neurologists, this was just published actually today. Because when I was sitting here, I got an email from the publisher saying it's out. It's free. You can just go to Practical Neurology website and look for the November-December issue. The whole issue has a special one on epilepsy, and you can read my article, and you may even see some familiar pictures. The other article that has been accepted, that's available online, in a preliminary version is this one, which also has some of these sodium channel discussions, but it has more because cenobamate has a larger story than selective sodium channel inhibition. So next I'm going to go to talk about this potassium channel target, KCNQ2-3, which is the current voltage gated KV 7.2 and 3. So here we want to activate them because remember, we want to push on the brake, right? So this is a channel that is what we call tetrameric. There are 4 subunits. 2 of them are 7.3, 2 are 7.2, or KCNQ2 and KCNQ3 gene products. And what they do basically is enhance the hyperpolarization. The current is called M current because long before we knew the genetics, they have seen this current with muscarine, and that's why they called it the M current, that hyperpolarized. And what you see there is orange is with the M current suppressed. The blue tracing on the top right is with the M current activated. So with these medications, you leave the neuron for a longer duration hyperpolarized. So it's going to be, this is called a term you may not be familiar with. It improves the spike frequency adaptation. That's the technical term, neurophysiologically. So this is of a lot of interest to me. You can see here 2 articles that I participated in. They came in the same issue of Epilepsy back to back because in 2012, when retigabine, which was renamed by the FDA ezogabine and was branded as Potiga, came out, neurologists were unfamiliar because we have never had a compound in that class. So we wrote this on the MOA and also on the spectrum of anticonvulsant efficacy. Then we brought it to our lab where we were really interested in studying, in my lab, a method called rapid kindling because we are particularly interested in pediatric situations in our lab. Baby rats, you couldn't kindle them over 2-3 weeks because they go through different developmental stage. So we modified a technology that was developed by Eric Lothman at the University of Virginia before he passed away. and we modified it a little bit so we could actually begin the kindling in the morning and have the rat kindled by late afternoon. Right? It's a different paradigm. And we used that and we studied the effect on retigabine. At that time, retigabine was not released yet. It was under development by Valeant, and we had access to the compound. So I want to show you here a couple of typical curves, what drugs do to kindling. So this is on the y-axis, kindling or seizure severity, and on the x-axis, days of stimulation, and you see the effect of eslicarbazepine. It kind of decreased the severity of seizures, but things were still moving along. That's with the sodium channel blocker, eslicarbazepine. Below is levetiracetam or Keppra, and what you see is it delayed the kindling. It didn't completely stop it. But in our experiments, in that paper I mentioned to you, the title, on the retigabine, you can see only the red curve, that is the vehicle. You don't see the retigabine curve, even at a very low concentration, because the retigabine is the green line that's hugging the baseline. So we were very impressed that in baby rats of postnatal day 14 and 21, 21 is a weanling, 35 is like an adolescent, right? What happened, unlike any other pre-existing anti-seizure medications, retigabine shut out. It was not a delayed or inhibition of kindling. It was a complete block of our ability to kindle. So we were very, very impressed by this drug. And retigabine came. And what happened was, unfortunately, in short order, I think earlier you saw a very graphic picture of the blue nails and mention about the dimerization and the retinal deposition. So that was a significant problem with retigabine. That's what resulted in GlaxoSmithKline pulling it back. But it also had significant issues with, particularly with some of the older patients, with urinary retention. That was not a trivial effect. Okay? So, what was the problem with retigabine? Now here for a moment I'll wear my medicinal chemist hat and walk you through this. See, what you see down here is so-called toxic intermediate. It came from that thing in the red oval. See that two nitrogens, both has a proton? If you have that, you can oxidize it to a reactive intermediate. It's called the imine quinone, and that's what dimerizes. And it also is highly pigmented, and that's why you get that color deposition. So we have new compounds now where that cannot happen. So we have two compounds. One is azetukalner, that's the xenon 1101, and then we have opakalem that just got the name. I really like that name. Whoever is from Biohaven, I want to tell you that's a great name, because kalem reminds you of kalium, is the Latin name for potassium. That's why we call it K, right? Opening kalium is a very nice name. So both these compounds are resistant to this quinone-diamine pathway, because you see they don't have these two nitrogens on both sides of the, you see azetukalner, you have nitrogen, but it's what we call a tertiary nitrogen. It doesn't have there's no hydrogen there to oxidize. So these are safe from going through this. One of the exciting thing is they are under development for focal epilepsy, primary generalized epilepsy, but very interestingly, another area of mine that we studied for almost a decade, published tons of papers in our lab, was giving labs temporal lobe epilepsy and studying development of depression and all the pathways involved. And what's really exciting is these compounds are also being studied for major depressive disorder. That is a huge comorbidity. And in classic studies from Frank Gilliam and people like Andy Kanner, we know that quality of life in epilepsy is much more affected by comorbidities and drug side effects. So if these medications actually can also manage depression, that's a great bonus for patients. So the latest in that story, I thought that was busy enough because I have many friends at Xenon and very close friends also at Biohaven, because the medical lead is one of my former trainees and fellows, Dr. Lerner. So anyway, I thought that was kind of interesting, juggling those two relationships. And now it turns out Jazz just acquired a potassium channel opener. It's called SAN 2355. This just kind of came out a few weeks ago, very new to me. And it's made by a company called San Iona in Copenhagen. So what is new about it, and what I understand, is it not only avoids dimerization, but it's very, very hyper-selective for Kv 7.2 and 3 over 7.4 and 7.5. And they think 7.5 may be a big driver of urinary retention. So one of the interesting things about this drug is it's not just selective towards 2 and 3, it actually blocks 7.5, meaning it should absolutely not have any urinary retention. So that seems to be the claim. We'll have to eventually see. And so this was new to me. I did not know Kv7 was important in the human detrusor. I just gave you the reference to show that that's indeed the case. So blocking Kv7.5 may be a good thing. Unbeknownst to you, 7.1, by the way, is the cardiac one, right? Okay. 7.1 is the one responsible for prolonged QT syndrome. So let's move now to the GABA system. And in the GABA system, a concept that's not commonly appreciated is there are two subtypes, major subtypes of receptors, those that are in the synapse and those that are outside the synapse. They are very different in their properties. The synaptic ones give rise to very sharp inhibition that looks like a reversal of the action potential, and they are sensitive to benzodiazepines, barbiturates, etc. The extrasynaptic ones have a different subunit composition, and when they hyperpolarize, it's a very sustained hyperpolarization. So we use the term tonic inhibition rather than phasic, as in the synapse. So this is the sensitivity of benzos, etc., and ganaxolone. These, normally, the extrasynaptic ones are activated by progesterone metabolites. These are commonly referred to as allopregnanolone, as well as TH-DOC, stands for tetrahydrodesoxycorticosterone. Okay? And so we have cenobamate and ganaxolone as ligands for that site. At the moment, ganaxolone, as you know, is approved only for CDKL5 disorder, a very selective situation, and is used TID. But the use of cenobamate there is very interesting. So what I want to show you here is the same synaptic versus extrasynaptic, but here you see the physiology in the bottom. iPSCs are sharp, but tonic current looks like a bump, and you can see ganaxolone, and then here is cenobamate. So what's the importance of cenobamate affecting the tonic current? If you look closely at the tonic current, one thing you can immediately see is it looks exactly like the mirror image of my obsession over the paroxysmal depolarization shift, right? It's exactly a bump, but in the opposite direction. So we are blocking the persistent sodium current, as I showed you earlier, but we are also augmenting I-tonic with both ganaxolone and cenobamate, but cenobamate in particular, with blocking INAP and augmenting I-tonic, makes it even less likely that you can form a paroxysmal depolarization shift. And that may very well be why Amanda showed you that 21% became seizure-free, and in post-marketing, in open label type of situation, more than 30% are becoming seizure-free. compared to barely 5-6% with other drugs. So I think there is some percentage in my argument that you should leave your inhibition alone. The other thing is there may be benefit to some tonic inhibition. Okay? So this is just the paper on cenobamate and GABA responses. It shows you that it's on the tonic inhibition side. It's not reversed by benzodiazepine blockers like flumazenil. And here again, there are other interesting properties in people with frequent seizures, like during status, the synaptic ones get internalized, whereas the extrasynaptic ones remain available. So that's where allopregnanolone to cenobamate, general anesthetics all work. So those are available targets. And finally, if you repeatedly activate GABA receptors, you may concentrate, as you notice in the mature neuron, there's a pump called KCC2 that removes chloride from inside the cell so that when the GABA channel opens, chloride can go in. But if you keep activating it, too much chloride can accumulate. That could be one of the reasons, not the entire reason, because I told you those receptors get internalized. But also if you accumulate too much chloride inside the little, small synaptic vesicles, right, and the boutons on the processes, you're going to not be able to effectively drive any more hyperpolarization because there is too much chloride inside. So one of the approaches that is being thought about is a compound that can activate KCC2, pump chloride more effectively, more efficiently. And that has been tried in benzodiazepine resistant seizures. And here you can see the power spectrum and preservation of cells. So this is a compound now originally made by AstraZeneca, now in the hands of Ovid, called Ovid 350, OV350. And I would disclose that I'm a scientific advisor to Ovid. Now we go to serotonergic targets, another interesting evolution, and you heard a little bit earlier about 5-HT2C, and I'm going to tell you a little broader story than 2C. Okay, so we have two important compounds in this domain, that is 5-HT agonists that are fenfluramine and bexicaserin, the Longboard compound that is now part of Lundbeck. I used to spend a lot of time with Lundbeck in the clobazam days, trying to educate people on 1,4 versus 1,5 benzodiazepines and on GABA subunits. Anyway, what you can see here is bexicaserin was specifically designed to be a 5-HT2C superagonist. The big advantage of that is lacking 2B. 2B is mostly a peripheral serotonin receptor, mainly in cardiac, and it may cause valvular fibrosis, right? It changes gene expression and activates fibroblasts in target sites. However, fenfluramine is not just 2B and 2C, it actually blocks the serotonin reuptake, SERT. So in a way, it promotes serotonin release, so it's very polygamous. You'll kind of dance with any serotonin receptor. And on the cardiac side, it's not a great thing, but it may be a pretty good thing on other counts, and I'll show you why. But this is some of the findings on Dravet, and here you see preliminary results again from bexicaserin. Very profound effects on Dravet with both compounds, and both are, one of them, fenfluramine, is also approved for Lennox-Gastaut, and you can see bexicaserin looks promise there and other DEEs. But what is interesting is 1B, which we used to mainly associate 1B and 1D with the triptans for migraine, right? But here you see that it may actually modulate electroshock-induced generalized seizures. So that's kind of an interesting finding. And this was study done by GSK many years ago. Then this one really caught my attention, 1D receptor, because this was a very specific study on the Dravet mouse. This is a mouse with the SEN1A gene knocked out, and in that it did both, was anti-seizure and actually prevented early death. So 1D is actually seems like a relevant one. And then another one that's kind of interesting, an older paper that is on 5-HT2A, comes from a very reputable lab, Carter Sneed from Sick Kids, an excellent pharmacologist of 50 years. What's interesting about it is we always lament that we don't have a good animal model for LGS, and that's true. So that kind of hampers our therapy development. However, what Carter Sneed had was a particular model that was drug-created that had atypical absence. It had slow spike and wave. We have had inbred rats with regular spike and wave. Those are the Geyers and the Wag Ridge. But these are animals where 5-HT2A receptors activated, rather blocked, and they developed atypical absence. So the point Carter made was if you activate 2A, you would actually abolish slow spike wave. So that's kind of exciting if you have LGS, because atypical absences occur throughout the day and fairly frequently. And part of the cognitive and behavioral side effect is being in a semi-stupor state. So you can expect that some of the behavioral things Amanda talked about, right, that they are getting better, that may actually be partly 2A. And then there are studies that if you put animals on learning tasks, memory tasks, there is 5-HT4 activation. So the behavioral things that Amanda showed may benefit from both 2A and 4, whereas 1D may very well be important in both SUDEP and seizures. And then this is the 5-HT1D result. You can see very dramatic difference in survival of these animals. You see life expectancy rapidly dropping during placebo vehicle, and then the gray line is with treatment. So it seems like a really sensitive target for abolishing SUDEP. And then there was this study from Carl Feingold's lab in Illinois, an investigator who's been studying SUDEP for a good long time, and they showed that fenfluramine prevented seizure-induced respiratory arrest, or SUDEP type of phenomenon, in the DBA1 mouse at a much lower dose than it took to even control seizures, suggesting it's not secondary to seizure control, but it is a primary independent effect. And later they showed that this was actually 5-HT4 activation. Okay? So, now there is some human correlate to this. This is a paper by Helen Cross, who just stepped down from being the ILAE president, a very dear friend of mine for a long time, from Great Ormond Street. She led the group that published this paper using the registry from baseline registry from Australia, from Ingrid Scheffer's group, and to show that both all-cause and SUDEP mortality were dramatically reduced. And Amanda spoke of this, and my initial thought used to be this must be 5-HT4. Now I'm thinking it may be combination of 5-HT1D and 5-HT4. Okay? So I'm going to be wrapping up. The emerging thoughts on ASM targets for SUDEP. This is a new slide that kind of emerged after recent explorations into different targets there. And so what we are learning is from the Feingold laboratory about 5-HT4, and from the Catherine Commons laboratory, that's from Harvard, Boston Children's, that 5-HT1D may be useful targets for protection against SUDEP. We also learned from Jeff Nobles that mice with loss of function in the Kv channels and gain of function in the SEN8A sodium channels, they all experience seizures coupled to robust spreading depression of Liao or spreading depolarizations. So it appears that the Kv7 openers that people are excited about may be, are the sodium channel blockers that target INAP. The two major classes I have been lecturing to you about, both may actually have the benefit of SUDEP prevention. So for all of you who keep talking about Quan and Brody, eat this. We may be getting great seizure reduction. With Kv openers, we may be having effect on depression. And to boot, we may even have benefits to SUDEP. So it's not true that we are not going anywhere. We are going some good places with small molecule therapy that's way more accessible, than more complicated and million-dollar treatments. So I think this is very exciting. So my final thoughts are, small molecule therapeutics will remain a major option for most patients. Very likely even patients who undergo gene therapy. I heard Neurona trial on the high dose. 72% seizure reduction is nice, but that's not, you still need something, right? So I think what I try to develop for you is how chemistry is now leveraging what we are learning from molecular genetics. This is a lecture I give to our epilepsy fellows because a large number of epileptologists are still talking Quan and Brody, but they're ordering gene tests, but they're not transferring gene test results into how it affects neuronal circuitry and excitability of the network. Because you're not going to get that by genetics consult. They're not neuroscientists. That's our job to learn that. And then for the chemist to apply that knowledge to create more molecules, right? And so we have all these new channels, many of whom you heard about clinical trials. I won't apologize for being super technical because my goal is really to get doctors more excited about these trials so you, the patients, can have access to them. I want the doctors to know drugs a little bit better than simply knowing, 50% seizure reduction and responder rate. So that was my goal. I hope it was of some interest even to people who are not neuroscientists. I thank you for your attention. If anybody has questions, it's welcome. Anything? Anybody? Comments? Questions?
I have PhD in H2, and within that we have the loss of function, gain of function, and mix. So just based on this, I think that would only be relevant to our loss of function patients. So with gain and mix,
Yeah.
do you think that moving forward, small molecule therapies will still be relevant for them, or do they need to kind of just go with the ASO?
The ones where some genes are really more complicated, where both gain of function and loss, this is not only true for the KCNAs, there are some calcium channels that are like that, like CACNA1. 1A is involved in Lennox-Gastaut with both gain and loss. For them, I think there's a real challenge. At the moment, we haven't found the right approach. We have struggled with also KCNT1. That's not proven to be. Maybe we need to learn a little bit more about how to manipulate them. They remain. I know a few patients with KCNA mutation that have been very, very difficult with the existing medications. Yeah. Anything else? Yeah, my only disappointment, maybe this should be in a CME thing. There are not enough doctors here, and my goal was to bring into the trial more doctors to wisely choose trials based on their practice and to understand the medications. We really need to somehow find the right place to put this lecture. So there are more, I hardly see any epileptologists here. Yeah. Yeah.
Yes.
Yeah. Okay.